this is the start of our revitalized lunch hour webinar sessions, which we were doing in the Northwest Haemoglobinopathy Coordinating Centre over the course of the last 12 to 18 months. But I think due to sort of staff changes, they sort of fell by the wayside. One point I'd like to make, a huge thanks to our colleagues in Yorkshire, South Yorkshire and the North East. As part of setting these up once again, this is very much a collaborative exercise between the two HCCs, and we'll be alternating sort of the coordination of these webinars between the two HCCs moving forwards. Just a bit of housekeeping. We've got some time at the end if anyone's got any questions. Presentation should take sort of 30 to 40 minutes, I would think. If you just keep yourself on mute, if you've got any questions as we go, pop them in the chat and we'll revisit those at the end of the session. The session is going to be recorded. We'll edit this sort of after the webinar is finished, and we'll be posting it on a variety of social media platforms. When it comes to the end of the session, obviously, if you've got any questions, just pop your hand up and we'll run through as many as we can. I'll hand over to Louza to run through things. Thanks, Louza.
Oh, thanks, Tom. So today we'll talk about it is actually in general topic of understanding of sickle cell disease, managing and advanced treatment. Thank you so much for the opportunity to present today. I'm glad to be to be with you guys today, and hopefully you enjoy the session today with me. Next slide. So the content of presentation is actually, I'll give introduction about sickle cell disease. I know you are expert enough to know about sickle cell disease, and we'll talk about a bit about disease modifying agent, and then go to allogeneic stem cell transplant and gene therapy. Next slide. So what is sickle cell disease? As you know, this sickle cell disease is an inherited disorder. It caused by a mutation in hemoglobin gene, and affect approximately 15,000 individuals in UK, and predominantly are Black African or Black Caribbean. So it is autosomal recessive disease. So it is inherited from the parents to offspring. And what's going on with sickle cell disease? Because of this gene mutation, the red blood cells actually, due to hypoxic stage, become sickling. And when it's become like sickle shape, so it block the blood flow, and that causes the painful crisis. And also we have a premature breakdown of the red cells, because the sickle cells are really fragile, so it's easily hemolyzed, and this causes a chronic anemia for the patient. And because of these complications, definitely it will affect the other organs. So there will be a long-term organ damage and complications. So it's affect the brain and cause stroke. So and the stroke will be like in early stage of the life, and even in early adulthood. Can cause cardiovascular, cardiopulmonary disease, and cause pulmonary hypertension, and can also affect the kidney by causing a chronic kidney disease, affecting the eye, because of chronic hemolysis cause jaundice in the eye, and with a patient can cause also retinopathy, and definitely it will cause acute and chronic pain crisis. Next slide. But despite all these challenges and symptoms that the patient present with, the management of sickle cell is improved significantly over the years. And today we'll explore the current treatment, and I will introduce the advancement of sickle cell care. Next slide. So currently, the current treatment modalities for sickle cell disease as you see, it is like from since long time is more or less as same. So it is a symptomatic management. If the patient present with the painful crisis, definitely analgesia will be provided to the patients. It might be simple analgesia, and we can give also advanced analgesia in terms of opioid. And the patient need to receive folic acid because the patient might have as I say, chronic hemolysis. So folic acid will be like a standard of care. And sometimes, definitely, patient will require vaccination, immunization because of the hyposplenic state of the patient with sickle cell disease. Sometimes they require erythropoietin if they have chronic kidney disease and anemia, IV fluids, because just to prevent dehydrations, antibiotic as a prophylaxis. We provide the patient antibiotic as prophylaxis lifelong because of the hyperfunctional spleen. And also sometimes patients will require blood transfusion, either top up or exchange transfusion, depend on the indications of the depend of on indications. And the cornerstone of management is hydroxycarbamide. So I'll speak a bit about hydroxycarbamide in details in next slide. Next slide. So disease modifying agent is hydroxycarbamide. Next slide. So hydroxycarbamide is remain the cornerstone of sickle cell disease management. It's effective for reducing complication and improve the quality of the life of the patient. So what is the mechanism of hydroxycarbamide? It is increase the fetal hemoglobin, and by that will reduce sickling of red blood cells and will decrease the rigidity and inflammation that provided during the painful crisis, and improve overall blood flow and reduce clumping of sickle cell disease. And the benefit of hydroxycarbamide, definitely it will reduce the crisis in terms of frequency and severity, and also lower the need of blood transfusion and protect against the organ damage and improve the life expectancy of the patient. Once indicated, so it's indicated nationally now, it's used like in adult and children more than 9 months of old, and for frequent painful crisis. And also it's used for chronic sickle cell disease complications if the patient, for example, have a recurrent acute chest syndrome, or the patient has chronic kidney disease. So in all these complication or chronic complication, we recommend hydroxycarbamide. But it is not suitable during pregnancy due to potential risk. So we advise all patients to stop hydroxycarbamide 3 months prior to conceive. Next slide. But as at for any medication, we need to have a monitor for hydroxycarbamide. So the hydroxycarbamide requires regular blood test monitoring. We monitor the white blood cells, platelet, and hemoglobin level because it causes bone marrow suppression, and by that might reduce the levels of white cells, hemoglobin, and platelets. And however, the bone marrow suppression is like a rare risk of hydroxycarbamide. That's why we keep monitoring the patients. And the common side effect, it is mild nausea, maybe fatigue, and skin discoloration. What is the limitation of using of hydroxycarbamide? Delay the onset of benefit. It takes several months to see the efficacy of hydroxycarbamide. So the patient and medical and healthcare professional need to be a bit patient to see the benefit of hydroxycarbamide. And the patient need to adhere to hydroxycarbamide to see the effectiveness. And some patients may not respond to hydroxycarbamide as any medications. Next slide, please. The next disease-modifying agent, but still under studying, under investigation, is L-glutamine. So it is FDA approved and shows that help improve red cells flexibility and reduce oxidative stress. And by that, it may lower the frequency of painful crises. So it's approved for patient age 5 years and above with sickle cell disease. And it's shown that to decrease the painful crisis event and hospitalization rate in a clinical trial. The common side effect is usually nausea, constipation, and abdominal pain. So the patient tolerate the L-glutamine. It is coming as like oral powder, can take twice daily, mixed with the liquid of soft diet, but it is not available in an NHS. Next slide. A third medication is mitapivat, is also under investigation. We have Rise Up trial for mitapivat. And it is actually the early results are promising, and hopefully that can be available in the next few years. So mitapivat is pyruvate kinase activator. It is improve the red cells energy metabolism and helping maintain their shape, and it's reduce destruction. So by that, reduce hemolysis and improve the hemoglobin level and reduce frequency of sickle crisis. And it's usually given as orally twice a day dose. Next slide. Mitapivat, as usually, it is generally is well tolerated, but the patient required to be monitored for the side effects, especially the changes in the liver function. So as I said, is still under trial. Long-term safety and efficacy of mitapivat is not yet well known. And the most side effect is really tolerable, like headache, nausea, vomiting, insomnia, dizziness, and sometimes joint pain. And for the joint pain, by the way, the patient know if it's like sickle pain, because they know what the sickle pain how does look like. So usually they can differentiate the sickle pain from the other pains. So the joint pain and muscle pain can be as side effect, but as I said, it is low grade, and sometimes increase liver enzymes like ALT and AST, and need to be monitored closely. Next slide. And we have also voxelotor, but unfortunately, voxelotor is withdrawal due to it is withdrawal by Pfizer volunteer, and in September 2024, after data indicate higher than expected risk, which is including increase the vaso-occlusive crisis. We have few patients, they said the vaso-occlusive crisis really, like, if this doesn't change the frequency, but in terms of severity of crisis itself, it's really severe. We thought initially due to voxelotor because new medication, but we are a bit, we are not sure about it. But then after the report, it's evident increase the vaso-occlusive crisis, and also it is withdrawal because fatal events that outweigh the drug's benefit. And the withdrawal includes stopping all ongoing clinical trials and also expanded access program globally. So patients currently on the drugs are advised they advise to contact all the patient and stop the drug immediately. So we contacted our patient and we stopped the drug immediately. And of course, we provide alternative treatment option, but we don't have, to increase any alternative option to increase hemoglobin level other than mitapivat, which is in clinical trials now. Next slide. So what is the definitive management or curative option we say now? So the curative option is allogenic stem cell transplant. It is the curative treatment available for sickle cell disease, but we have eligibility for stem cell transplant. It's best suited for patients with severe complications such as recurrent painful crisis, stroke, or organ damage. The donor match should be HLA identical sibling donor. However, now it's under trial also. We have alternative donor like haploidenticals or unrelated donors we might consider also under clinical trials. Conditioning patient will required, of course, to undergo chemotherapy to suppress the immune system and ensure the donor stem cells can engraft effectively. Next slide. So survival rate, it's exceed 90% with HLA identical sibling transplant, and the event-free survival, which is no rejection or severe complication, is around 80 to 86% depending on the donor types, and many patients achieve long-term cure and eliminating disease symptoms. So as I said, we can now we have an option of haploidentical, which is half matched, and from a non-relating donor or a relating donor. And also the studies now try to reduce or eliminate severe episodes of complications due to transplant. Next slide. So as I said, allogenic stem cell transplant is limited available due to matched donor, and we have less than 20% of patients have HLA identical sibling donor, and the risk include graft versus host disease, rejection, and transplant related complication. It is highly cost and intensive follow-up required after the transplant. And advances and future perspective, advances in the haploidentical donor and reduced intensity conditioner are expanding now, and we have like expanded access to it. And the research into safer method is ongoing to improve the outcome and reduce the risk. Next slide. As I say, we are now in 2025, so we have like advanced treatment include autologous gene therapy. So it is promising autologous option for sickle cell disease and to involve modify the patient on stem cells to address the underlying genetic causes of the disease. We have so far two approaches that are available, which is to modify the genes. We have a CRISPR-based editing and gene addition, and both approach are aimed to restore the normal hemoglobin production. Next slide, please. Yeah. So this is basically, so we are harvesting the stem cell from the patient after mobilization, and we take the stem cell to the lab and we edit the stem cells by CRISPR Cas9 repair mutation beta globulin gene. And after that, we give the patient chemotherapy, and after chemotherapy, we infuse of the edited cells to the patients and waiting for engraftment. And after the infusion, post-treatment recovery, patients are closely monitored for complication and require definitely extended follow-up care. Next slide. So gene therapy, it is potentially cure, and there is significant reduction or elimination of the vaso-occlusive painful crisis, and doesn't require any donor since the patient is his own cells are used, and there is no risk of rejection or graft versus host disease. However, there is challenges, of course, for everything. So the side effect include the risk of chemotherapy-related complications, infertility, or potential secondary cancer due to the chemotherapies used in this treatment, especially that we use busulfan in the conditioning regimen or conditioning chemotherapy. And long-term treatment or long-term data, it is further research is needed on durability and safety over decades. Next slide. And that's it for today. I give you just brief about what is sickle cells and what we have in terms of treatment and the future, hopefully, treatment for sickle cell disease. And thank you so much for listening. And anybody, do you have any questions? I'm here to hear your question and hopefully answer them. Yeah.
Hi, this is Rebecca Proudford. I'm a pediatric consultant in New York and lead for sickle here. The L-glutamine and the other treatments, are they things that you give in addition to hydroxyurea, or are they alternatives?
There's no alternative. They give it with a hydroxycarbamide. There's not any of alternative. And to be honest with you, it is like it doesn't show a lot of reduction in painful crisis. But though for them as a study, it showed decrease the painful crisis and event and hospitalization rate by, I guess, 35% or less than that. So it's not really benefiting.
So, sorry, which drug are you talking about?
L-glutamine.
Oh, okay. But in these studies, are they all given in addition to hydroxycarbamide?
Yeah, they are.
Yeah. Okay.
Yeah.
Thanks.
In addition to hydroxycarbamide, it's not like as a monotherapy.
Yeah.
Yeah.
Okay. Thank you. That's really interesting.
Yeah. Welcome. Any questions? No. So that's great. Since there's no questions, so I did very well. Yeah. Any chat questions? So I'll check the chat. Oh, sorry.
Question around sharing the slides, Louza, if you're happy. I can circulate that.
Yeah, please. Yeah.
Perfect. I'm just looking at the chat now to see if there's any questions.
No, I don't know.
There was a question right at the bottom around.
We don't use luspatercept for sickle cell disease, but there are studies that use it for beta thalassemia. So it's like in sickle cell disease. We don't use it here even in NHS. It's not available for beta thalassemia. No, it's not mentioned, luspatercept, no. Yeah.
Any other questions?
Yeah.
What we'll do, I'm going to take silence as a note. What we'll do is we'll share the slides imminently after this session. Like I say, the recording will be available via a variety of our social media platforms. As part of the sharing of the slides, if you've got any questions that you want to ask offline, I'll copy everyone in attendance in, as well as obviously our lovely, wonderful guest speakers. So you can use that as a mechanism to ask any questions that you may have offline. Perfect. Thank you, everyone, for attending. Sincerely appreciate it.
Thanks.
Thanks very much.
Bye.
Thank you.
Have a lovely evening. Bye.